I'm a professor of medicine in Mohammed bin Rashid University and a consultant endocrinologist in Dubai Hospital. Great pleasure to be with all of you here at the EDIC 2026. And in this dialogue, I have the honor and pleasure to be with a good friend, Professor Chantal Mathieu. Chantal?
Thank you, Dr. Hassanein. Indeed, I'm Chantal Mathieu. I'm an endocrinologist from Leuven, Belgium. And it's also my honor and pleasure to be here in EDIC and have this discussion with you. It will be on type 1 diabetes.
Indeed, and not just about type 1 diabetes, but potentially on the possibility of prevention of type 1 diabetes. But perhaps before we go into this, maybe it would be important for people to understand how do people develop type 1 diabetes?
Yeah, so the last 20, 30 years have been instrumental for better understanding type 1 diabetes. We have better understood now that the problem is our immune system. Our immune system attacks the only cell in our body that is able to produce insulin, and that's the beta cell in the islets of Langerhans in the pancreas. I weigh my words for not saying autoimmune disease. It is, of course, an autoimmune disease in that it's our own immune system attacking the beta cell. But some people say, well, it's not really an autoimmune disease because, yes, there is a genetic predisposition. It's polygenic, more than 50 genes, major genes being the HLA class 2 genes. But we also know that it's not enough, just a genetic predisposition. There seem to be triggers from the outside. Some viruses are implicated, enteroviruses that seem to play a role in starting the autoimmune attack, polluants, the fact that, interesting, our children are becoming more obese, thus putting more stress on the beta cell and making the beta cell more vulnerable to the attack of the autoimmune attack. So it is an immune disease. We know that many cell types in the immune system are implicated in the attack of the beta cell. But we know also that it's the T lymphocytes that will eventually kill and destroy the beta cell.
Very, very important points for everyone to understand how does it develop. But with that understanding, are we closer to be able to predict that a person, a young person or older person, will be highly probable to develop type 1 diabetes?
Yes, and there's different ways of talking about this. First of all, we can just look at a person's genes. So we can take blood in neonates and run a genetic risk score, including 30, 50 genes, including the HLA class 2 genes. And then we can identify a person's genetic risk of ever developing the autoimmune disease. For instance, in Caucasian people, the risk of type 1 diabetes development in the overall population is approximately 4 in 1,000 for a newborn child. By running the genetic risk score, we can enrich the risk in identifying people who have now a risk of 1 in 10 of getting the autoimmune disease. But that's a genetic risk that we can identify. It still doesn't guarantee you will get the disease. What we can now also do is identify people who already have the immune disease, who are already attacking the beta cell, and that by finding biomarkers in the blood of people, namely antibodies directed against the beta cell. So we can identify risk, genetic risk, theoretical, or we can now identify people who already have the autoimmune attack against the beta cell by autoantibody detection in the blood.
This is quite important because it also leads to the point of we now understand that type 1 diabetes does not have to be diagnosed with an acute emergencies. There are stages for it. Would you like to elaborate a bit more on this?
Indeed. I mean, we are a generation of doctors who have been taught that the diagnosis of type 1 diabetes is an acute event. You have symptoms of polyuria, polydipsia, weight loss that appear a few days, a few weeks before we as doctors make the clinical diagnosis. And unfortunately, often this is accompanied by diabetic ketoacidosis. We have data from Europe showing that in children under 18, this is about 44% of children who present with clinical type 1 also in ketoacidosis. And so this is quite disruptive in a person's life and in a family's life. Children often have to be taken into ICU, and unfortunately, we also have mortality, especially in the very young ones. But so the concept of being able to diagnose people now before this clinical stage, namely by the presence of 2 or more types of autoantibodies in the blood, opens up a new perspective, because now you can diagnose an individual when there's still normoglycemia present or dysglycemia present. And this gives you time to introduce the disease, to prepare the family, to start monitoring glucose, to educate, and to prevent the presentation in diabetic ketoacidosis. And that is why the Juvenile Diabetes Research Foundation, they call themselves now Breakthrough T1D, has proposed a couple of years ago a new concept of type 1 diabetes, where we have now stage 1 T1D, being people who have 2 or more types of autoantibodies present but are still normoglycemic. Stage 2, 2 or more autoantibodies present and dysglycemic. And stage 3, the clinical stage type 1 diabetes that we used to know with hyperglycemia.
And if left, they will be stage 4 or 5 with
Correct.
serious problems.
Correct. So there's also a stage 4 where you have the full-blown type 1 diabetes, unfortunately in many also accompanied by chronic complications.
So Professor Mathieu, you've been part of a nice document that provide guidance to doctors of who to screen and how to screen and how frequent to screen. Give us a bit of insights into this, please.
Indeed, you are alluding to the consensus on screening for early stage type 1 diabetes. And this will be published very, very soon, where a group of international experts came together to discuss, first of all, is it now time to advocate screening in the general population for the presence of early stage type 1 diabetes? And second, how should we do it? And I'll come back to that immediately. But just to say that already in 24 we published a document on how to monitor people that you have identified. Because we chose to do it in the reverse way, because it's so important that if you think of installing screening for early stage type 1 diabetes in your population, you need to be sure your system of doctors, of nurses is ready for the follow-up of these people. Because once you find the people, you need to monitor the people. It's quite easy. It's really a common sense. The younger a child is with appearance of autoantibodies, the more aggressive its immune system is, and the more frequent you need to follow up. Follow-up is easy. It's just hemoglobin A1C and glucose. So in a young child, we will follow up these children every 3 months. If the child is above 10, 12 years, we will follow up every 6 months. And if it's a young adult, we will follow up every year just with a hemoglobin A1C. So the monitoring, the education is easy. So now we were ready indeed for the screening advice, where we say, if you've never screened before and you are setting up your system, you may want to start with screening in those who are genetically at a higher risk. So if you've never screened before, setting up screening in families, extended families, not only first degree but second degree, whatever, people with an increased risk of autoimmune disease, who already have other autoimmune diseases, for instance. If you've never done it before, start small scale. But eventually come to setting up screening of the general population. And there you need to be a bit pragmatic. We say try and get screening in the very young, because that's where you have the biggest gain when it comes to preventing diabetic ketoacidosis. The very young children, 2-3 years of age, have trouble presenting with symptoms. They, a child drinks a lot. It's hot outside, they play, so it's not easy. So we advise, if you want to set up screening in your population, you may have a first window between 2 and 4 years of age. Those who are negative, invite them back 3 years later between 5 and 8 years of age. And those who are negative, if you have the money, invite them again between 10 and 15 years of age. So these are guidance. But if you say our system only has money to screen once, Israel, for instance, is screening at 5 years because then they have a thalassemia screening. Other countries associate it with a vaccination at 6 years or at 4 years. So it depends how your healthcare system wants to organize it, for instance, together with another pediatrician contact.
So you mentioned one important point, the prevention. So once we screen a person, a young person, and we identify that they are at risk, can we prevent the progression or regress the progression of type 1 diabetes?
To me, that question is really what made the difference in my attitude 10 years ago versus now. 10 years ago, my story ended with identifying people in an early preclinical stage of type 1 diabetes, educating them and the family, accompanying them, monitoring them. But we couldn't do anything. Now the world is different. First of all, several clinical trials are running to see if by making the beta cells stronger or affecting the immune system, if we can prevent the course. So trials are happening. But the excellent news is that we now have a first drug approved for use in people who are in these early stages, namely teplizumab, an antibody directed against T lymphocytes that have CD3 on their surface. So teplizumab has been approved for use by FDA, by EMA, by many countries all over the world for use in people with stage 2 type 1 diabetes, namely 2 or more autoantibodies and dysglycemia. We know that these people have a very high chance of progressing to clinical type 1 diabetes. If you have stage 2, you have about 40 to 50% chance of having clinical type 1 diabetes in 5 years. If you're young, higher. If you're older, lower. But so in this group, stage 2 type 1 diabetes, we can now use teplizumab. It's an infusion. It's an infusion of 12 days to 14 days. It depends on the area of the world, but mostly we have 12 to 14 days, just one time. And then you gain 3 years of delay. So this is quite important because, as I said, also several trials are running to see, can we combine it with something? Can we make it even longer than a 3-year delay in the progression to clinical type 1 diabetes? But so the difference, Mohammed, is we have now an immune intervention to delay the progression.
And just for clarification, EMA is the European Medicine Agency and not the Emirates Medical Association, which is the overall host for our Emirates Diabetes Endocrine Society. But that is an important point of being able to delay the onset of diabetes for some people. It might be expensive, it might be hectic, but I suppose many kids and many parents would like to prevent what's inevitable. But do some people feel that it's going to happen anyhow? What's the point of delaying by 2 years?
Absolutely. And that's why it's so important to discuss it with the family. I mean, I think the times are past where we as doctors decided for a person. When we talk about cancer therapies, we discuss with the person and we say, these are your options. And so I think we as a medical profession have the task to discuss now these options with people. Some people will tell you, I do not want to know if I have preclinical stage type 1 diabetes, but at least we need to inform the families. We need to tell them we can screen for this disease, and if you have an early stage of this disease, we can now do something. This is the intervention, this is the cost, these are the side effects. And side effect profile is very acceptable. During the infusion, the 14-day infusion of the teplizumab, you do have some fever because of the infusion of an antibody against T lymphocytes. So some fever during the infusion that we can cope with medication. And then some liver function abnormalities, but that's it. So we have a task as medical profession to at least inform the families, and then they can decide.
And on top of the infusion and the specific drug, they could work on trying to avoid the environmental factors that can expedite the type 1 diabetes. As you rightly said in the lecture, I like the expression of soft landing.
Absolutely.
Do you want to?
Yes, absolutely. And so buying time, giving you months and years to prepare. For instance, we offer in Belgium to people in stage 2 type 1 diabetes a continuous glucose monitor, because they learn from behaviors. We know that obesity seems to be not a specific trigger, but at least an accelerator in the progression. So healthy lifestyle, introduction of this healthy lifestyle is not only good to avoid type 2 diabetes, but it's good for your health as a whole. And for instance, having these sensors also worn gives you an indication when glucose levels are going up and when it's time to contact your healthcare provider, if it's sooner than in the 3 months or 6 months or 1 year you were supposed to see him anyway for monitoring.
So this is really quite exciting time for people with type 1 diabetes. I think from the dialogue and from the presentations that we had in the conference, our understanding of type 1 diabetes now is a bit different. We know it's an autoimmune condition, but what we can identify now is there are measures to avoid the sudden acute emergency of a type 1 diabetes presentation. We can identify certain antibodies that would precede by many months or even years the development of type 1 diabetes, and that can maybe be an active process for screening for people with type 1 diabetes. Perhaps the screening would be across the community, or perhaps it would be targeted to those who are maybe at higher risk of developing the problem. And then once the person and their family know that this is the case, then there are certain measures. Potentially could be treatment to delay the progression, but certainly a change in their lifestyle, avoiding the other triggers which would exhaust the pancreas further, and monitor the changes in their lives. And possibly this will help them to adopt a healthier lifestyle, which really would be better anyhow.
Yeah.
Any other additions?
Yes, so what is important is that there's also hope for those already diagnosed with clinical type 1 diabetes. So I said we also have many interventions that we are testing just at the time of clinical diagnosis. Because as we as a medical profession get better in diagnosing people early, in creating awareness in the population, we also see that we identify people in stage 3 type 1 diabetes, so clinical type 1 diabetes, a little bit earlier, with still 20% of functional beta cell mass left, especially in adults where the evolution is slower. We should remember that 50% of people only progress to clinical type 1 diabetes as adults. So in these people, there's still quite a few beta cells to be saved.
Yes.
And so a lot of trials are ongoing to try and save these beta cells. Because as we know, Mohammed, having a little bit of functional beta cell mass left makes your life easier. Because it's like a thermostat of the air conditioning. It goes up and down depending on the needs. And so it makes your brittleness of type 1 diabetes less. So there's hope for these people. And then it's a topic in itself, but the islet transplantation domain is evolving very rapidly. Because now many companies can make from stem cell research, they can now make beta cells. They can make liters and kilos of beta cells. So trials are ongoing. And what we learn from immune modulation in the early stages, we will also be able to apply once we replace beta cells in people who already have existing long-standing type 1 diabetes. So it's strange, but we were always very fatalistic when it came to type 1. Type 1, it's done. Now I believe we can be hopeful that this is a disease we will be able to arrest in its tracks and even eventually cure. I don't know when it will happen, but as we speak, trials with these transplantation of beta cells are happening, with the new immune modulation is happening. So I'm very hopeful this will be a disease that we will treat completely differently.
And with this very optimistic note, I think it would be good to finish our discussion. There is hope for detection, early detection, prevention, and perhaps cure for type 1 diabetes. I've enjoyed the dialogue very much, and Chantal, welcome in Dubai.
Thank you.